I might try to be able to.
Okay, sir. Okay, good morning. Staff meeting Tuesday, May 21st. I want to apologize up front. I have to leave at 10 a.m. sharp. I have a 6th grade and a 4th grade graduations that I have to be at. And these are important, so I've got to be there.
And I have to leave at 10:30 for this very soon.
Kids' graduations.
Is there any grade that they don't graduate from?
No, they graduated every
Up and
grade.
down every year.
Every single grade now. So we'll get to moving. Manager Stoltz.
Good morning, Chairman and Commission. One topic today, but it is a heavy duty topic, and we'll try to be as efficient as we can with time. We have representatives from IMA here today. We're going to talk about the health and prescription benefits for Sedgwick County moving ahead in 2025 and beyond. The presenters today will give you a financial update. They'll give you renewal projections and comparatives, a utilization review, and as is interesting every few years when we do this, there's industry trends which are ever changing in the world of the health field. So I'm going to have Sheena start us off, and then she will introduce our guests from IMA.
Thank you, Tom. And again, good morning. This is a fun topic that we're going to be talking about, and we've been working on this for several months. I'd first like to introduce our Sedgwick County team that has been working on the benefits in the RFP process. Anna Meyerhoff-Cole, Connie McAfee, Sarah Meek, Cheryl Orm, and Lindsay Poe-Rousseau from HR and Finance. And also Laura Oblinger from the Sheriff's Office, Kevin Nelson from Fire District Number 1, and Kathy Wagner from ComCare. In addition, we've been working with our consultants, IMA, and I would like to introduce Diane Thornton, who is the Vice President, Vanessa Keith, who is our Account Executive, Jill Cooper, who is not here today, but also our account manager, and Katie Ertz, who is online with us today and is going to walk us through some of these financials. So we appreciate her jumping online. She is in California.
Well, welcome, everybody. We're glad you're here.
So we will be cognizant of the time. If you do have questions, we want to make sure that we answer those. The items that we're going through today, as Tom mentioned, we'll talk about what we went through with this RFP process, what the trends are, and just know that we've gone through bid board and you will see this item tomorrow on your agenda, regularly scheduled agenda. So can I have the PowerPoint pulled up as well? Okay, there we go. The first thing I wanted to start off was, during this process, one of the things that we felt was quite key was to ask our employees what they wanted out of their health and prescription insurance. And that is the two things that we are focusing on today. You do have a packet in front of you, and we will try to go slide by slide and make sure that you're in sync with our PowerPoint up here. I'm going to talk very briefly about this survey, but the entire survey is in the back of your packet under supplemental materials. This is a survey that went out in late March through April, asking the employees several different questions about their current services right now, including what is covered and what networks they prefer and things of that. I just wanted to point out item 3, when we ask employees what benefits are most important to you, we had them rank those things. And when we get into plan design, we are going to take employees' feedback and incorporate that into how we create our benefits for the upcoming year. Items that we saw of interest were lower office copays, reduced copays for outpatient mental health services, which is something that I think we've seen for many years. Weight loss medications, we've seen that is a national trend, so we've had a lot of conversation about that. Hormone therapy, bariatric surgery, and fertility benefits. And then down below, you can just see a word cloud of what employees discovered when we asked them how they felt about things. And they talk about thing of having that coverage, that benefits shouldn't cost an arm and a leg. They want these types of services. So we know that this is something very near and dear to employees. And as we've gone through this process, we keep centering back to how does this affect the employee? So with that, I am going to turn this over to Vanessa, and we're going to get moving on the financial update.
Good morning, Vanessa.
Good morning. Thank you for having us today.
So I'll be very short and sweet. Today, the presentation is dealing with the financials tied to renewal themselves. We will not review in this meeting contract and benefit changes. That will be at another time, as well as ancillary lines of coverage. We will just be speaking of financials and part of the RFP for the third-party administrator and the pharmacy benefit manager that we have completed. Katie will take over from here and talk through the financials with you guys.
All right. Good morning, everyone. We'll be going over just the total cost slide at first. So this is slide 5 or page 5 for you that follow along on paper. I want you to gain from this slide is to look at the pie chart on that top left corner and realize how much medical costs of claims make up your total spend. So if you look, the gray section is your net medical claims. The light blue section is your net RX claims, which is almost 94% of your total health spend. This was for 2023. So a large majority of your cost is due necessarily the TPA or admin fee, which we'll be touching on in a little bit when we review the marketing options that have been discussed. That was the extensive project that we've been going through the past couple months. So it's most important to make sure that you're choosing your correct medical network rather than focus on the TPA fees. So we'll have a bunch of buildups that go into this in more detail, but I did want to point that out. TPA fees is the purple section, was actually too small to even show up on this pie chart, and then $20,000 was annually spent on that. We can move on to the next page. This is a financial update. I'll walk you through what is on this slide since I know we have a lot of numbers going on. At the very top, you can see the periods listed out. We have a current period of January through December of 2024. This is actually just year to date through March. As we don't have claims data available, obviously it's only May, and there's also a lag in that claims period delivery time. Then the prior year is 2023. And then we have also listed out the average employee count. So you can see the employee count has upticked a little bit, about almost 100 employees greater for 2024 year to date compared to 2023. I did want to point out that PEPM, you'll see that quite a bit in the presentation, stands for employee per month. It's just a metric that we use to normalize claims on a basis per employee per month. For example, since you did have an increase of employees in 2024, normalizing the data on a PEPM basis helps us compare each year to year. Down at the bottom, in that first table, we have the gross medical claims listed to the left and the RX claims right next to that. Reimbursements, those are going to be stop loss reimbursements from large claimants and also RX rebates that are paid out. Then we have our net claims. So that's just taking medical and RX, adding it together and then subtracting out that third column. Farther to the or next to the right is administration cost. You can see that 73 cents PPM. That's what you're currently paying for UHC admin costs. So that corresponded to the slide that we just looked at a little while ago, that $20,000 that was too small to show up on the pie chart. And then we have our stop loss premium that provides coverage for large claimants. And then our total expense PPM. So just adding up those admin and your stop loss, your fixed cost portions to those net claims. So the far 3 left columns get added up together to add up to that far right column. You can see the total paid amount for 2023 is listed down in that 4 row. It's 31.6 million. I want to point out that medical claims are a good driver of claims that have decreased in 2024 year to date. Down at the far left corner in that top table, you can see a negative 10.2%. That's medical claims decreasing from the prior year. RX claims did increase that 0.5 change, but it was very minimal. So that's really good news that your medical claims, the majority of your cost driver, are decreasing. RX costs, I'm sure you see all the ads on TV and everything. It's a huge talking point lately of how much RX costs are increasing. So the fact that it only changed by 0.5% on a PEPM basis is also great news. Overall combined, that was a negative 6.8% change in that middle column for net costs, and then including fixed costs, that was a negative 0.62% change. So all good news on that your claims are performing better for 2024. so far year to date. Down at the very bottom, or sorry, in the middle, we have the health plan. This is showing how much is employer expense and budgeted, and then also a surplus and deficit. So currently year to date, there is a 1.6 million surplus. And then it also illustrates out the employee contributions. That is 710,000 for a total of 7 million net cost. And this is again year to date for 2024. Down at the bottom is just a snapshot looking at large claimants. Last year there was 11 for the full year. Year to date, there is currently only 1. Year to date last year, there was none. So we are on schedule or on running similar to last year for large claimants. We can move on to the next slide.
Katie, I might stop after some of
Yes.
this information and ask the commission if you have any questions or if Katie needs to go through anything before we move forward.
Well, I kind of do have it's more for finance, Lindsay. When you see this, what do you look at in regards to budget and forecast? What numbers are you focusing in on?
So what we focus in on, for obviously per employee per month, right? Because we always want to know what contributions ought to be, from both the, county side and from the employee side. Although that gets more complicated, and what this does not delve into, nor should it, is the 3 different plan options that we have. We also obviously care a whole lot about the annual amounts and the total value of claims. So what they are showing you right now are actuals. And so that would compare to a forecast, right? When we actually go into a budget process and we work with IMA closely on this, we will inflate that number slightly, just to make sure that we have enough budget authority there to pay whatever claims may come in. So I think all of this is really helpful, but the admin costs are really important as we talk about which of these TPA plans to go with. But then in terms of what we look at, it's really those claim dollars for medical and prescription. Does that answer your
It
question?
does, yeah,
Okay.
it does. Commissioner Huff?
Yes. So the estimated employee contribution is a negative number, $97 per month. First of all, it says total, how do you get from 97 to 710?
Yes, that's taking the employee count for all the way through March and multiplying it by that $97.
The total number of employees times $97 times 12.
Yes, but then you also times it by 3. It probably will not match exactly because we did use actual counts to come up with that 710 number. So the enrollment listed at the top is just an average if you took the 2430.
So curiously, why did the contributions actually go down?
Down from last year. So just
What? Yeah.
it could be enrollment shifts, changing tiers. If an employee goes from employee plus family and then their spouse also has coverage, and those employee or spouse and dependents move to that plan, just shifting in tiers. If an employee gets divorced and moves from employee plus, family tier to employee plus children.
So the employee count actually went up a little bit year over year, and the per employee per month total cost for all employees for the year went down. It just surprising me a little bit that it did go down and that much. $710,000 is a lot.
So 710,000 is not the difference. That's the year-to-date contributions. We just show it as a negative number to get to a net employer cost. So if you're looking at like that middle section, we have the 9.3 million is your total budget, or the total employer expense is 7.7 million. That 710 is a negative to subtract off of that cost to determine what Sedgwick County as an employer is paying. So the 710 is how much contributions have been tracked or accounted for year to date so far for Sedgwick County through March of 2024.
This is a year-to-year comparison though, correct? I mean, this is not saying just because we're partway through the year that that's the cause of this number being this is a year-to-year comparison, or no?
Not the middle table. So sorry, that was not super clear. The middle table is just year to date.
Okay. All right. Thank you.
Yes, I apologize for that confusion.
All right, Katie, we'll move on to the next slide.
Okay, sounds great. We will be looking at page 7. So this is just a historical review of comparing funding versus actual costs. We do have 2022 and 2023, and then 2024 is annualized. That gray chart line that you can see drastically decreases corresponds with this table below. So you can see we're comparing the actual cost trend. So that's that 30.7 million that happened in 2022 up to that 31 that we've already seen for 2023, and then 2024 is just annualized. This is just an estimate of taking claims through March again and then multiplying it by 12 to annualize that number, is actually showing a decrease for 2024. So that's a negative 2%. This is total actual cost trend. So this does not count for like any enrollment changes. Up at the very far right-hand corner is the PPM trend, sorry. That is a 5.1% increase. So that is also very good news that it's not large of an increase and is right on trend of what we would expect or even below average for the industry. All right. If there's no questions, we're going to be moving now into the renewal projections. So we'll flip to page 9. This is the start of setting so we'll review the slides to review basically what was set for the budget. At the far left, we have that same table again showing 23 total cost, that 31.6 million that we've referenced. That's again illustrated in the right. This is probably a better indication of the employee contributions that we talked about on the prior slide with those questions. That $710,000 was year to date. But the employees in 2023 paid 2.5 million, and in 2022 they paid 2.4 million. So there was a shift up of $100,000 from 2022 to 2023, and that was an increase of 0.6. Down at the very bottom, we just have 2024 budget this is annualized. Currently we have the admin $21,000. So that's that low purple cost that's not shown on the pie chart. And then we have stop loss, which is at 1.1 million. And that adds claims is 36.4 million. So that total together is 37.5 million. And employees, yes, go ahead.
Can I pause you there? Can we talk about stop losses really quick? Because I don't know that we've had that conversation the last few years with commissioners.
Yes, of course. So stop loss is paid for is that $1.13 million in premium, and that covers Sedgwick County's large loss coverage. So any claimant that goes above $450,000 will be covered by stop loss. Let me just double check. I believe it's 450. 500,000. Sorry about that. So any claimant above $500,000 is covered by the stop loss premium that is paid out. This just provides protection for the county. So if a claimant does reach above that point, then the stop loss coverage kicks in, and all those dollars above $500,000 are paid for by a stop loss carrier. So it's just a way to protect employers from large losses and minimize their risk. It's very common with self-funded, unless you're a super large employer. I would say above 5,000, 6,000 employees enrolled on your plan. Typically you would see an employer have stop loss coverage.
Thank you, ma'am. Commissioners, any questions about that? It's basically insurance for our insurance.
1.1 millions are we pay in stop loss coverage?
Thank you, ma'am. We're ready to go on. Sorry to stop you.
No problem.
Voice in the sky.
All right, now we're going to move on to page 10. And this is going into the budget. So if you remember on that last slide, I talked about the 37.5 million that is seen as the current on both of these tables. The 2025 budget is projected at a 2.9% increase. So $1 and change, bringing it up to 38.6 million. At the very top, this is just broken out in PPMs again to normalize it. And this is how we project claims going forward. So we'll come back to an underwriting projection where you'll see the actual math that led to this percentage increase. And we'll talk more about the claims and the increase from 2470 to 1278. So that 2.6% increase. Again, we're showing the admin is at 73. That'll come up in a little bit. And then your stop loss premium at 1.1 million is $44 projected going forward, but currently it's at 38.94 PEPM. I want to note that stop loss is not available until we have data through July or August. That's just how stop loss works. They need to know what large claims are kind of coming up in the pipeline. So unfortunately, that is just an estimate. We have applied a trend percent increased of 15, which is the average trend for stop loss currently. Questions? If
No
not, we
questions
will.
at this point.
Okay, I just looked down and saw that you had already moved on to the next slide. I'm behind. So page 11 is now we're getting into the marketing conversation. We have the 3 marketing options, and then we also have current. So we have UHC at the very top. You'll notice that this number is a little bit different than what we talked about on the prior slide. The prior slide was a budget recommendation. This UHC number has been adjusted differently, mostly due to RX rebates, just because we wanted to make UHC on the same playing field as the marketing options, and make sure we were comparing apples to apples for all the options. We have marketing option number 1 was Aetna, and it would actually bring an increase to Sedgwick County of 1.2 million. Option 2 was Blue Cross Blue Shield of Kansas, and that would also bring an increase to Sedgwick County of 566,000. And the last option is a standalone PBM option. So the first 3 options and what you're with UHC are bundled, meaning your medical and your PBM are all combined with one carrier. It's like one ID card. It's a little bit more simplistic on the admin side, just a little bit more straightforward, where you can also have an option to carve out your PBM piece. So just taking away the pharmacy or RX portion and only remain with UHC for medical. That is the marketing option number 3. We did see a little bit of savings for that option, but pretty minimal when you think about total spend, as the savings was only $270,000.
Before we move on from this slide, these will be the options that the group went through and reviewed. And I will make a comment on option 3. When you do see a little bit of savings or change there was also disruption that would happen to the employees with that change. So what we did was we looked at how much of those prescriptions that employees currently have, and if we were to change that over X amount of employees and X amount of prescriptions, if you would be disrupted or possibly not even covered moving forward. So when we view that as, yes, there is savings, there's also another expense on the other end as well. What? That's correct.
UHC,
Yes.
and our book says that on the second line. So it's-
Yes, it should say Blue Cross Blue Shield. Yes. We just realized that in the book.
So will we be getting a preference from you all? Okay.
Yes.
Thank you.
And in fact, we've already gone through bid board on that process, and we'll be walking through that today.
Thank you.
And that's why the timing is what it is for this workshop, because we did, in order not to have any issues with sharing things before bid board had seen it, we had to make sure we got through that process before we could talk about these details with you. But we wanted you to have this information before you voted on it tomorrow at a commission meeting, when you'll have a bid board recommendation. So that's why this was separated out from the rest of your budget workshops, just that timing.
So a couple questions. If you go back one slide, you're looking at budget. So Sedgwick County, we're looking at plus 2.9% increase. How does this impact the employee, the individual employee? Is there a coverage change? How does it impact their premiums? How does this impact them?
So right now, we have not looked at what our plan design will be. So we do not have those rates set yet. That will come after the vendor is selected. We'll work with IMA, knowing what those charges will be for any upcoming cost, and we'll have those blended in before the recommended budget.
Before recommended?
Yes.
Okay.
And I do want to point out to that end what you see in a recommended budget is going to be much higher because again, this is only medical and prescription. It doesn't include dental, vision, life, those other benefits that you all have already approved through a separate process. So just don't expect to see a $38 million health and life fund budget. It will be higher.
You're full of good news today, aren't you?
Just proofing this slide or page 10 here, it says renewal PEPM. That bottom number in the red box versus, the numbers are different. The current is the same, but the renewal, the bottom number is not the same in that red box. Is that an error or is that something else?
Yeah,
One
that's
is
just a
38
type.
one says 38,663, 616. That one says 38,684, 937.
Yeah, that's just a typo to the
Which
enrollment.
one's
sheet,
right?
so, yeah. Thank you for catching that.
You know which one's right?
I believe the top one, some silly.
Thank you.
Yes.
Okay, moving forward, we are on page 12.
Yes, okay, so we just looked at the summary of the marketing options, and now this slide is for the visual learners to break out each of the sections. The following slide will go over the same information, just in a table format. So if you are more of a table learner, you can wait until the next slide to see all the same information. At the very top, we have the 3 bundled options. So as I talked about on the prior slide, these are the options with medical and pharmacy carved in together. So everything is bundled, and that's why it's illustrated as a bundled option. The last option 4 is with UHC again, but with the PBM carved out. You can see the savings listed or the increase in costs again listed to the far left. And then we'll get into these bar charts. So that gold section is the RX rebates amount. This varies per each vendor based on pricing and network discounts, just as you would go to the store and get different pricing for the same product. Say like a Target versus a Walmart, it's similar things apply here, where just different carriers are gonna have different pricing. That's what leads to the variance in RX rebates as well as medical and RX costs. So the dark blue section is medical claims, and then the gray section is RX rebates. So for example, you can see UHC at the very top, we have 23.7 million for medical claims. That number matches the same number down at the bottom for UHC. With the carve out option, just because that medical carrier would be the same, you'd still be remaining with UHC for option number 4. However, the RX costs on those different options do vary because RX costs would vary with the different vendors. You can see Aetna and Blue Cross Blue Shield would be switching PBMs and medical vendors. So those medical and RX costs vary for each one of those. And then moving forward right, we have the admin costs as that light blue number. So with UHC currently, because of you being bundled, you get a discount on your admin fee. That's that $20,000 that we've been referencing, which is really low compared to the market. I can see an average admin cost would be closer to $1 million. Blue Cross Blue Shield of Kansas also did give a kind of discount for being bundled, but their discount was far less significant than UHC with currently. The next option or next category is the purple color, which is stop loss. Again, that's just estimated at a 15% renewal. And then the far right, the little white box is margin. So claims margin is added into these projections to set at 2% to account for claim fluctuation and differences in claims as we go forward.
Quick question. Sheena, you talked about that 4th option, Caroline. You said there'd be disruption. You're talking about user disruption, employee disruption. Is that what, can you help qualify what kind of disruption would they be facing?
So we have a little note that UHC moving to Carolina would disrupt 6 members with 18 total.
18.
Yes, and then also disruption to pharmacy locations. There would be an additional administrative burden for Sedgwick County. Also could be administrative burden for employees if, different file feeds, if you have prior authorizations and those have to get fed over to a new PBM, there could be disruption just with transition between different vendors. There can be too.
Yeah.
issues that have come up.
And that was something that we looked at with all of them, was what would that disruption look like as well?
Very good.
Perfect.
Any
Okay.
questions on this slide?
Any
Okay,
questions?
I'll move on to the next slide.
Katie, hold on. We do have one question.
You say prescription rebates. Please explain who's getting the rebate.
Yes, so the rebates are paid out to Sedgwick County. They're on a quarterly basis. They are significantly lagged. So you might remember on the budget conversation that I did mention that's why the UHC number looked differently. That's mainly because of rebates in the payment time. So each quarter a rebate is paid out, but if you move to a new PBM starting in 1/1/2025, an RX rebate payment, the first payment wouldn't be made until around September. So it's almost a 9-month lag before that first payment occurs. And then your fourth payment would occur 4 quarters from September for 2025. So it's a quite significant lag period of time. But those rebates are paid out to Sedgwick County. As you can see, like it varies across each carrier. Carillon had the highest rebates, but their RX costs actually did increase too, even though the rebates were more significantly. And just the variance is due to pricing differences, different networks. They're able to negotiate those rebates with the PBM.
The only one that does not have a disruption on this pharmacy is the top one here. Everything else has got a disruption, so to speak. So let's explain this rebate a little bit further. So the employee goes and fills a prescription. They make a copay to the distributor or the dispenser, if you will. Where's this money coming from and why is it going to Sedgwick County? What's going on there?
The pharmacy benefit manager is collecting that from the manufacturer. So the manufacturer supplies a certain dollar amount in prescription drug rebate. Really what's happening is they're trying to offset the cost of their medication on the formulary that you have, so your drug list. So they're saying, we'll give you a $5,000 prescription drug rebate, and that'll make our drug the cheapest option on the formulary for preferred pricing. So it's incentivizing for pricing on a formulary. That's coming directly from the manufacturer to the pharmacy benefit manager and then distributed from the pharmacy benefit manager to Sedgwick County.
And can I jump in here, Commissioner? Those dollars go directly back into the Health and Life Fund, and we count on those dollars when setting rates. So employees do see the benefit from those prescription rebates because we are able to keep the overall premiums down that folks have to pay. So it comes back to Sedgwick County, but I want to be clear that it comes back to this fund only. It's not like a general fund subsidy.
So there are some, I consider to be mainstream pharmacy, dispensaries around the community that are not part of the UHC PBM. They're not recognized. And I don't know why that is. I don't know. For example, if an employee wanted to go to one of those places to get the same drug, and why would they? Again, there may not be a rebate back to the county to lower the price of the drug, but if the employee still gets a better deal there, why can't they still go to the other dispensary to get that drug if that's a better deal for the employee?
There's a network of pharmacies that are covered underneath the United Healthcare drug list. And unfortunately, some are out of network. That wouldn't affect rebates whatsoever because the rebates are based on the prescriptions paid through the plan. I think there've been conversations about trying to add the pharmacies that are in network here or out of network here, but at this point that has not happened.
I guess what I'm saying is, even though they may be outside the recognized, PBM recognized pharmacy, recommended pharmacies or whatever to get your prescription drugs, there still may be a better deal someplace else, but there's zero benefit if you go outside the plan. There's no insurance benefit if you go outside that plan.
It processes as out of network. Yeah.
Right. So in other words, basically there's no insurance benefit whatsoever at that point if you go outside the plan. So for example, let's just name a name. If you go to Dillon's or Walmart, you might be able to get a drug that's inside the plan and you get some negotiated price. It sounds like in that situation, the manufacturers then through the PBM send money back to Sedgwick County.
Mm-hmm.
If someone wants to go outside that pharmacy, they want to go to a different dispensary. some of these drugs are more expensive at Dillon's, for example, than maybe they set prices at different pharmacies. They just do. I don't know why that is.
Mhm.
Some drugs are cheaper here versus there. They just are. So it might still be to the employee's benefit to go to a different place to get that drug.
Mhm.
But there's no benefit from the county, no benefit from insurance whatsoever on going outside that.
That's correct.
I'm not quite sure I'm understanding exactly everything that's going on here, but that's, I need to get some more help on this one. All right, thanks.
Okay, Katie, we are moving on to page 13.
Okay, so we will just touch on this quickly since this was the same information that we saw on the prior slide. It's just illustrated in a table format instead of the chart format. So you can see the variance a little bit easier between different, say, medical claims, the different network pricing that affects those medical claims. Going forward, we're going to be looking at the underwriting. So I wanted to focus on UHC a little bit so you can follow along with how we get from these numbers to the next slides. So if you add up the 2315 of the claims, medical and RX claims, subtract out the rebates, and then also add in the margin, you get to the next slide total, which is 37 or 35.7 million down at the far right at the top of that red box that's highlighted. So I just wanted to kind of follow along so you understand how we're getting to that total number. So this, what you're looking at is the underwriting or math portion that leads to the projection of how we determine a budget, or also determine the total costs on those prior two slides. So this is only looking at claims. So as I said in the prior slide, you're only looking at the medical claims, RX rebates, and then also the margin. Those the stop loss and the admin don't remain or are not shown at all on this slide. And it's just looking at the claims only, just how much the claims would be affected by changing networks. So all of underwriting, any sort of projection is going to look at a prior period. So for this underwriting, we have 3 periods. We have the farthest period to the far left, middle period in the middle, and then the most recent period on the far right. We place the most amount of credibility on the most recent period so that you can see that in that bottom yellow row that has a percentage, 70% credibility is weighted on the most recent period, and that goes down as the periods get older. At the very top, we have medical claims. Medical claims are applied to trend, and we also back out stop loss large claimants, and then we'll add them back in after claims. This is just underwriting methodology and how you approach projecting cost going forward. The trend that we did use was 6% medical trend, which is average claims cost trend going forward for medical claims currently. And then RX claims are down in that middle section. RX claims are listed, and we also do trend those numbers forward as well. RX trend is a little bit higher, it's at 9%. And that number is applied to the medical claim or RX claims to forecast how much RX claims are going to cost going forward. Down at the bottom and the far right, we blend it all together. So as I said, we've taken the most credibility and put it on the most recent year. And that's where you get to the 1351 ppm. That's that blended claims number. Next line below that is the RX rebates. So the RX rebates that we were just talking about and how Lindsay said that is incorporated in your budget. This is where they're added. They're subtracted out from that blended claims number. So it's a true dollar for dollar off of that claims number. We get to 1201 ppm. That's with claims without margin. Then we add a 2% margin and get to 1225. The most important thing to take away from this is we're going to be looking at this underwriting slide for UHC also compared to the 3 other marketing options. So if you want to compare each slide, you would be staring at the like negative 1.7% decrease. That's a decrease in claims versus how that's going to compare to the other carriers. I know that's a lot. So is there any questions?
It is very complex. I will say that we have spent a lot of time going through these numbers and looking at those projections. So Katie, we'll go ahead and move to slide 15 on Aetna.
Okay, perfect. So as I mentioned before, UHC was negative 1.7. So compared to Aetna, it was negative 0.1. So UHC was a little bit more of a savings. Recall when you looked back at those summary slides, the bar chart in the table, that the savings for Aetna was, or there was no savings, there was actually a $1.2 million increase. That's because of the increase in admin costs, and then also how claims increased a little bit compared to UHC. So the difference between that -1 and the -1.7 all led to Aetna costing more when you add everything up together. So the same methodology was applied. The only thing that is different is that there was a network change. So you can see the yellow boxes are filled out with numbers. Those are adjustments that are made because Aetna's network, medical, and PBM network cost more than UHC. And since UHC claims is where we're starting at, that's our starting point, you would adjust for those additional costs and less discounts. All
And then
right.
slide 16, Blue Cross Blue Shield.
Perfect. So going on to the next slide, if I recall back at that same table again, you might remember that Blue Cross Blue Shield of Kansas was less of a discount overall. So there was a $566,000 increase for Blue Cross Blue Shield, which explains more in the, or is explained by the less of a discount here, the negative 0.8. So that's in comparison to the negative 1.7 that we saw on UHC 2 slides ago. So less of a decrease in claims. Again, we have adjustments for network changes in those yellow boxes. So the medical network for Blue Cross Blue Shield was actually much more significantly costed, like higher than UHC. Those are those higher numbers, $900,000 and $800,000. And then the network change for the RX network was actually decreased because their network pricing for PBM was lower. So that all is added up together and incorporated in this projection. All right, and then lastly, moving on to UHC with Carelon. So no surprise with this one, it is a larger decrease. This is the only option that did have a little bit of savings, but although the 6.1% might look really good, especially compared to the 1.7, that's just because of the claims cost decreasing quite significantly and the greater RX rebate, 6.2 million. But with this option, your admin costs for UHC would go up quite significantly from that $20,000 that we saw with the UHC bundled option up to 1.3 million for admin costs. So that's where most of this like decrease of savings is happening with the Carelon option, is because of that increase in admin cost. Since the UHC network is used, you can see the network changes at the top are 0 and those yellow. And then there is network changes for the PBM, which their network change also was higher costing. So those $200,000 are listed in that row for that. And then we have the RX rebates, like I mentioned, the 6.2 million included.
Questions on those options? Okay. Let's look at our 5-year projection on page 18.
Perfect. So this is pretty simple. This is just showing an average trend of 5% for total health costs. So again, just total health plan, medical, and RX costs, and also fixed costs blended up together of what an average budget increase would be. Just projecting out that 5% compounds year over year, and it would reach just above $45 million in 2029. So 5 years from now.
And that is something that Lindsay and Lorian and her team, when they put that together, that 5% trend, that's what we typically use. But you've seen in previous slides that we have come in under that over previous years. So that is good, but we're aiming on that 5%. Next, we're going to talk about our utilization review. So Katie, on page 20.
Yes. Okay. So we're switching gears entirely. And instead of looking at the marketing results, we are going to be looking at 2023 data. This comes from a utilization platform called CedarGate. And your carrier UHC feeds over the data into CedarGate. And this just gives us a greater indication of utilization. So think of, as you can see kind of a little bit on this chart, but how many ER visits there was, how many scripts there was, what is the higher costing drug. So instead of focusing on financials, it's more looking at what actually happened in the data. This data set is a little bit different than the financials just due to timing. So if you see a total number, it's going to vary a little bit from the financials that we did just look at on the prior slides. So with that in mind, our period of claims we're looking at, medical claims increased 3.2% and is much below the benchmark. RX claims also increased 9.8%, but it is also still below the benchmark. We had Humira being the highest costing drug, and that was followed by several weight loss drugs. And the average age is 31.9, so that's much lower than the benchmark. Depression reduced from the prior year and is in line with the benchmark, but we did see some upticks in other mental health categories, which we'll touch on in a little bit. You can move on to the next slide. So this is a summary of overall cost impact. So we have 4 categories that are pulled out here to the left that indicate how much the different categories your plan. So we have impact of demographics, plan design, risk score, and geographic location. So some of these, obviously, like location, you can't really affect very much, but there is ones that you could affect more often, which is like plan design. So your plan design currently, the benchmark is 75% of an actual value. That's like those values that you might have heard coming out with ACA, the metal tiers of platinum, gold, silver, and bronze. That's where these numbers come from. So your plan design, Sedgwick County's plan design is 79%, so a little bit above the benchmark. That leads to a potential impact on claims of per member per month. That's what PMPM stands for, a little bit differently than what we looked at in the financials of per employee per month. But that impacts $25 or a 5% increase. Your demographics, because of that lower average age, actually lead to a savings on the plan. I know this looks a little bit alarming being a large of an impact, but really this was skewed quite significantly just because of one large claimant that occurred last year. So because of that large claimant, that's why this is drastically higher of a percentage and higher of a per member per month impact for risk score. And then over at the right, we have everything summarized. So we have our total plan cost. Again, this is illustrated on a per member per month. That's $501. That's seen down below the reporting period, which is from February 2022 through January 2023 is a comparison period. Sorry, I read that backwards. The most current period was February 2023 through January 2024. So that corresponds with the reporting period illustrated right there. The prior period, you can see that claims were down a little bit on a per member per month basis, 474 versus 500. So an increase of 5% compared to prior. Any questions?
Questions?
Okay, now we're going to move on to a little bit more detail on the demographics, that savings that we talked about on the prior slide. This indicates your average age of 31.9, which I talked about in the very beginning, compared to the prior period of 32.9, so that's actually decreased. The percent females on average tend to cost the plan less than males. So that's why percent females are called out, 52.5. So that's up a little bit from the prior period, but below benchmark as well. And then the contract size, that's going to be average number of members per like family, essentially. So this is a in-between number because you have people who are employee only on the plan, employees plus spouses, and employee plus family and children. So the average contract size is 2.3, which is higher than the benchmark. The benchmark does see typically more employee only enrollment. So that means you have more families on your plan, but that has decreased from the prior period. Okay. And then we are moving into detail on mental health. I did touch on that depression did remain close to the benchmark and actually improved from last period. That's that far top left box, the 517, it's down from 524 in the prior period. However, everything to the right actually did increase slightly. So the office visits per 1,000, again, that's way to normalize the data is to normalize it per 1,000, increase from prior and are well over benchmark. Same with admins, mental health and substance abuse. Admins are much higher than the benchmark. The diagnostic spend, medical and RX, is also higher than the benchmark and increased quite a bit from the prior period. And pharmacy, this is just pharmacy, all related to mental health and substance abuse, is also increased as well.
So one of the reasons why we wanted to pull this information out and share it is because of what we've heard from employees, that they would like lowering costs to see mental health professionals as well. So we wanted to go in and see exactly what our claims were being spent for as well. We do know, and I think it's talked about in the community quite often, about providers not being in network as well. And I think that's another conversation that we have outside of this. But this just shows we do have usage for it. We do have medications and things that are diagnosed in regards to mental health.
Okay.
Patient care compliance on page 25.
Perfect. This is going over preventative services. Anything in red was below the benchmark. So, and then yellow is close or very similar to the benchmark, and green was actually an improvement. So this is the opposite than what you would normally look at data, and a higher percentage is actually better, since you want this percentage being the higher is the best. So 85% for preventative care, that was the largest decrease or largest delta of a difference between the benchmark and what Sedgwick County's data showed. So the benchmark was 92%. You can see cancer screenings were listed below that, and most of them were good, but there was a couple, mammogram and electrical cancer were right in line with the benchmark, but we're up from prior, so there has been improvement since prior period. Over at the right, these are just disease specific compliance rates. And you can see all the green again is good. So there was only a couple that were below the benchmark, which is great news on that side. We can move on to the next slides, page 26. This is going over chronic conditions. Again, green means good. You can see all the green over there, so that's really great. The depression and ADHD, so kind of what we talked about a little bit on the mental health slide, 2 slides prior, shows up here as the red option, or the red. So it did decrease, depression decreased from prior period. That was at 517 visits. But is higher than the benchmark, and then ADHD as well increased slightly and is higher than the benchmark. Over to the far right, we have top diagnosis. These are greatly also influenced by large claimants. So the 1, 2, and 3 are also, we're all impacted from large claimant diagnosis, and that's what really skews that data and the increase highest total cost versus the benchmark. And the same thing could happen also for the bottom ones. If there's a large claimant in the prior period that dropped off and did not occur in the most recent period, that would indicate a lower or greatest lowest decrease.
And finally, our prescription drug summary.
Yeah, so last slide, and then you will no longer hear me talking. So prescription drug summary is, this just goes over a bunch of different points related to prescription drugs. We have our per member per cost and scripts per cost and cost per script on that far top left corner. Everything was higher than the prior period. That's indicative of how we talked about earlier of the RX costs increasing. I remember on our financial slides, it increased 0.5%. And then on these utilization slides, it also increased a couple points. That's shown here in this data, that just cost per scripts and utilization was both up. On the far right, in the bottom, we list out top drugs. So we did talk about this a little bit. Humira was the highest costing drug. That did decrease actually from last year though, so remained pretty similar to last year, but a 4.9% decrease. Ozempic and Mounjaro were the next two highest costing drugs. You can see especially with that third drug, that high percentage of change, that's 794%, showing just how much that has changed from last year and become more of a prevalent as weight loss drugs increase in popularity.
Thank you, Katie. So we keep our eye on this information very consistently with UHC right now. We want to see, where our money is going, what types of drugs are being used by our employees, so that way we can view what those trends are in the overall cost. So this, I know it's a lot of information thrown at you, but this is stuff that is very important when we take all of this into consideration.
Sheena, a couple questions real quick.
Sure.
If that's okay. I read the bid board minutes, and so there are really good questions in those that I think will help provide some clarity. Thank you, Brandy Bailey and Rusty Leeds, for some of the questions you asked in the minutes. That the same questions that I had, and there was some clarity provided. I want to understand the experience that our employees are having with United comparative. My private life, we use Blue Cross Blue Shield. It's United here at the county. Family had a baby this year. I've had experiences in both networks. What are our employees telling us about United and the network of providers and the experience they have with this?
So again, if you flip back to our supplemental material, we ask employees about that. I'll get to that. We ask them how they feel about their health plan, which is on page 37. And overall, they feel like the plan is very well, very good. We also ask them, as you can kind of go through this, about how they feel about the network. And then we also ask them, again, some questions. What would you like to see? And I showed that at the beginning of, these are things that employees would like to view. One of the things that I think is maybe a misconception with insurance is that everything is covered all the time at 100%, and that's not the role of insurance. We do get benefits or reductions for being within network, but we also try to keep these within reason of what is covered at 100% as well. So I think if you ask employees, they would want everything covered, but not everything is covered. And when we, again, going back, when we go into creating our plan design, we want to take that feedback that the employees provided us and try to incorporate any of those changes in there as well.
Are these, what's the length? I did not see that in the bid board that we'll be deciding on tomorrow. These are 5-year contracts, 1-year contract. What are we looking at here on relationships?
It's a 3-year contract with 2 1-year renewals.
Okay, up to
Yes.
5. Okay, got it.
And just on the backside, so you're aware, there is a lot of work that goes in between human resources, ERP, and payroll on the backside of this. So they put in countless hours working with vendors and making sure files are accessible. And then our employees also have benefits available to them right away.
Very good. Okay. Other questions?
Well, let's talk a little bit about industry trends. Thank you, Katie.
Thank you.
So first, let's talk about inflation. So inflation has had an effect on the overall cost of healthcare, but not as much as we thought. Estimated trends, our trends are at a 6% increase trend on pharmacy, on medical, and a 9% trend on pharmacy drug. That means year over year, we expect medical costs to increase just in overall cost 6% more than they did the year before. That's what that means. When you look at the national trend studies, everyone's around that that trend line that we have, which tells us when you talk about your projected trend lines being under that, you're moving in the right direction from a cost perspective overall. I'll go to the next page to talk about the factors. So primary drivers on the medical side, one of them is tied to contract negotiations. During COVID, the facilities didn't have a lot of ability to contract negotiate. Now that the pandemic is over, they are negotiating, and they're negotiating more fiercely than they have ever before. There are larger claims coming to market. There are gene therapies out there that cost average $2.6 million right now. So there are costs that are coming to plans that are higher than we've ever seen before. Cancer is becoming more prevalent. A lot of that can be attributed to people forgoing services during the pandemic. We're seeing an uptick of cancer diagnoses now that they're getting those services. And then avoided care has caused a little bit of a trend increase as well. On the pharmacy side, specialty drugs, there are specialty drugs out there that cost $500,000 to $600,000 that don't have any alternatives out there. They're called orphan drugs, meaning there's no alternatives. So that specialty market is driving quite a bit of cost from a trend perspective. GLP-1s and weight loss. We've talked about weight loss a little bit. So GLP-1s are your Ozempics, your Mounjaros, your Wegovy's. Those are becoming more prevalent in the market. Those are also very expensive, over $1,000 a month per person. So those are driving quite a bit of cost. And then the overall cost of prescription drugs is increasing at a trend line that's much higher than medical because of those overall cost increases. Mitigation strategies. On the network side, we want to focus on the transparency for employees. We have a cost estimator with United Healthcare, which they can look up services, and it allows them to see exactly how much it's going to cost them up front and choose between providers from that. So transparency is key in ensuring that people are provided services and getting services at the lowest cost available to them. On the pharmacy side, we can always look at formulary and then sourcing options available that would allow us to source those high cost drugs at a different level. From an industry hot button issues perspective, condition management is becoming more prevalent. We're going to have to find a way as an industry to control those cancer claims as they become more prevalent in the market. As the workforce ages, those will become even higher. We also need to focus on mental health. Mental health is becoming more prevalent. The stigma has been lifted post-pandemic, and people are asking for help with their mental health care. That is something that we're reviewing from a benefit perspective with the county. Weight loss drugs and the coverage for weight loss counseling is going up tremendously. Not a bad thing. A lot of times, with morbid obesity or obesity, there are comorbidities that cause high cost claims like type 2 diabetes, things of that nature. So having the increase in weight management is not necessarily a bad thing, but it is a trend that we're watching. And then, like I said, transparency is important and key. We want employees to understand what the cost of care is and how to seek the cost of care at the lowest cost to them available at the highest quality provider. This is from a benchmark study from employer. This is asking the employee and asking them to rank every benefit available to them. As you can see, this is compared to government and public different size ranges in the Midwest and nationally. You'll notice that from a benefits perspective, health insurance, 401k, dental, vision are the top 4. You get into flexible work schedule, which is in the top 5 of every industry. It doesn't matter. Every industry is looking for flexible work schedules, even if flexible work is not available. I think the keys here are annual bonus incentive, cash in unused PTO, and then mental health are those that are coming a little bit higher than we typically see with other industries. And then the last slide is the offer rates on those selected benefits. So you'll notice that wellness programs are by and large being offered by everyone. The county offers a wellness program, and United Healthcare's offer has $100,000 per year wellness fund for the county to utilize. It's interesting because it's number 22 on employee priorities, but it is a program that the county feels strongly about and will continue to contribute to. Employee Assistance Program, EAP, is the number 4 on that list. That goes right into the mental health care, and that's definitely something we need to focus on too. Okay.
Questions for Vanessa? So I do want to bring this back. Commissioner Howe, you did ask on page 10. We went back and double checked those numbers on the renewal for the PEPM. And it is the 38,663,616. That is the correct number. Katie was checking on that while Vanessa was up and talking. So we apologize for that typo. It's just an oversight on our part, but that is the correct number. So we have presented a lot of information to you today. This is what, again, the panel went through, looked at, and went through many different vendors to select those down, and then ultimately to provide a recommendation to the commission. As you've seen, we are going to recommend to continue with UHC in a bundled group to keep our prescriptions and pharmacy, or I'm sorry, our pharmacy and medical together. We feel that is the best interest for the county financially, as well as for the employees with less interruption. Do you have any questions for us at this point?
This is coming to us tomorrow.
That's correct.
So we're making a 5-year decision potentially tomorrow. This is the first time we've seen these numbers and seen this briefing. I've had some significant questions about pharmacy benefit management for a couple of years now. And I'm not so sure that I like where we've been. I want to challenge. I'll just say this. Some of the competitors are arguing that, if I understand correctly, that they offer everything that the other pharmacies offer and more. And the costs in general are going to be saving our employees money. So it's the less cost to the employees. There's not a reduction in benefit at all. In fact, it's an advantage to the employees to have the other options. So I'm a little bit concerned about that's not been explored fully. I'm also concerned about a 5-year commitment, or, it's 3 years plus 2. I get that. But I still think we ought to be exploring maybe a shorter time frame for this, because I think there ought to be maybe a reconsideration on how we deliver services entirely. This is one of our most expensive things we do as a county. One of our largest expenditures is healthcare for employees. And the large employers in the private sector have gone in a different direction, which I think actually has provided better care for less cost for the employees and for the employers both. But we haven't taken time to explore it. And so I'm a little concerned about a 5-year commitment. Basic, here we are tomorrow at this time, this will be done. We have less than 24 hours basically to absorb this and make an argument to change directions potentially. I feel like this is not even giving us an opportunity to really seriously do a deep dive to even look at something else. I mentioned this at the en banc, and as far as I know, no one has even made a phone call.
The options that we did explore were unbundling our medical and prescription, and what was submitted through the competitive bid process did not, we believe, lead to benefiting the organization or the employees.
So I understand that's the process we followed. I'm actually asking to reconsider what we do and how we do it. And I wanted to take some time. If this was for 1 year, I would feel less worried about this. But for 5 years, we can't come back for 5 years and really do what we should, in my opinion, is taken the last year. We should have done a deep dive over the last year and reconsidered some ways to do how we deliver services to employees. If we can provide better services for less cost to the employer and to the employee, if that's something that's actually on the table out there in the private sector, which is why they're doing it, then we've not taken the time to do due diligence to even explore the idea at all. We simply just do what we do. It's the same old. We just what we do this every 5 years. The same thing comes up. We do it again and again and again. We're not taking time to reconsider how we do stuff. So is this a good plan? Sure, it's a great plan, but is it the best we can do? I'm not convinced personally this is the best we can do. No, I don't like the fact that it's being presented to us on Tuesday at 10 o'clock. We're expected to adopt this tomorrow at 9 o'clock.
I just want to, I hear what you're saying, Commissioner, but I just want to thank all the efforts that staff and IMA group and finance and everybody put into this. This is quite a book. It is a lot. It is a lot to unpack, but insurance is a area that's I'm glad I'm not an expert in, because I have to trust other experts. And I know we have Commissioner Lopez is fairly familiar with some of this. I'm sure more than the rest of us are, but as far as I'm concerned, I just want to say thank you for all the efforts that you put into this and the comparisons that you've showed us. So thank you.
Tom, do you have anything? Okay, I think that's all. Thank you.